Welcome everyone. Welcome to the first meetup, the Medical Education Meetup. Let me see. My name is Roel Swabers. I'm your host for today. I'm the CEO and founder of the Parantion company. And together with my colleague Robert Smeenk, he's the second speaker for today, we developed the Scorion system. This conference is organized by Parantion Events, and you can ask why we do that, or why they do that, because, well, it's very simple. We want to share and spread the ideas of a few interesting educational concepts based in the Netherlands, such as the EPAs and Programmatic assessment. So we're very excited to do this and to share this with you. I believe we have about more than 100 visitors or participants all over the world. I believe there's about 20 countries participating. We're very excited that technically we managed to do this in teams, because that was a bit of a challenge, but we managed. So we need sometimes a little help from you as participants, but I think we're going on during the day. And there's a second reason why we're very excited, and that's because we have a very interesting educational program. Before we go to that, I have a few housekeeping remarks. The first is that it's a confidential meetup, so we don't do anything with the addresses, except for if you want us to send you the information, you can use the QR code at the right side of the presentation. You can fill out your email address and we can send you the movie afterwards. And at the end of the session, there's a second QR code for the evaluation of the session of today. Well, you don't see each other. That's because we work in teams, so you cannot see all the participants. We don't see you as well. That's very easy for me because I'm just talking to my computer. And we have Q&A sessions between every presentation. Okay, I think that's enough about the introduction. I go now to the next slide. That's the program. Well, I'm starting right now. In a few seconds, we start with the presentation of Professor Nico Creugers, an innovative interprofessional dental clinical learning environment using Entrustable Professional Activities. And what we did for that presentation, it's a little different than we thought, and that has to do with some problems with the internet connection in Nijmegen. So we, just before this session, we created a small movie with the presentation of Professor Creugers. So, and after the presentation, after this movie, Professor Creugers will join us to answer the Q&A, so answer the questions. Then we have a presentation from Robert Smeenk, Programmatic Assessment and Entrustable Professional Activities in Medical Portfolios. And then also a Q&A session, and after that, who else? Professor Olle and Cate about Entrustable Professional Activities in health professions and education, health professions education. So after that, we have the closing. It's only a few minutes, and then I hope we all had a very interesting and very nice day. So now, I think it's time for the first presentation, for the first speaker. Here you see Professor Dr. Nico Creugers. I said it's an informal introduction because if I do a formal introduction, it takes me more than half an hour to talk about everything he has done in his life about the dental education. But he has led the dental education department at the Radboud Medical Center in Nijmegen for many years. I had the chance to do an education project with him together in China, and we share absolute a vision of innovation in the medical education. Well, I can't say give a big hand for his presentation. It's a movie, but still a big hand. I give the floor to Professor Dr. Nico Creugers. And now my colleague will start the movie.
Good afternoon. My name is Nico Creugers and I'm a professor of Radboud University Medical School, responsible for the dental education. The Parantion organization asked me to provide a keynote on an innovative interprofessional dental clinical learning environment using Entrustable Professional Activities, and I'm delighted to do so. Our dental curriculum is based on a few principles, but before you can understand why we have organized it in this way, it's good to have a little bit knowledge about the background, because not everybody attending this keynote is from the Netherlands. In the Netherlands, the undergraduate dental curriculum comprises a 3-year bachelor program and a 3-year master. The key figures of the Radboud UMC Dental School are, we have 76 new students starting each year, so 76 in each class. We have a total of 22/7 full-time equivalent teachers, amongst them 6 professors, and in total we have 300 employees, most of them working part-time at our dental school. The students have courses for 1,680 hours per year, which means that they attend dental school or work and study for 40 weeks of 42 hours. About 30% of that time are contact hours between teachers and students. Beside that, we host 240 hygienist, oral hygienist students who follow a 4 years program. But the oral hygienist students, they are organized in another organization. In total, our dental school has 128 clinical units. The educational principles we follow are listed in this slide. We offer our students a practice-based learning environment so that they can have a longitudinal integrated clerkship. We include interprofessional education, which means that dental students and oral hygienist students work together. Our education is competency-based, and we try to entrust our students at certain moments to do certain treatments by themselves. Self-determination and self-regulation are also important in our educational program. And we try to develop lifelong learning professionals. So learning by doing is one of the most important things in our master curriculum. The clinical program, the master curriculum, comprise a student-run dental clinic, which is for 8 hours per week during 3 years. And besides that, we have minors, we call it specialist minors, for 4 hours per week. These minors include reconstructive dentistry, surgical dentistry, a profile called child and development, and gerodontology. And besides that, we also have several internships. Our students go for 3 weeks to an affiliated dental practice somewhere in the Netherlands. We have 7 weeks internship at the Department of Oral Surgery, a 2 weeks internship in geriatric dentistry, also in another place in nursing homes, and we have a 2 weeks elective internship. The backbone of the master curriculum is the student-run dental clinic. It's organized in a way that 4th, 5th, and 6th year students, so Master 1, Master 2, Master 3 students, work together in a team. We have about 18 of these teams, which treat approximately 750 patients. And as said, 10 to 11 students are included, also 4 to 5 oral hygienist students, and they have 1 dental teacher, and for a group of 3 master clinics, we have 1 oral hygienist teacher. So the teaching environment is completely focused on interprofessional education. The teaching tools we used are team-based learning. We work with Entrustable Professional Activities. We include peer teaching, and also peer FAQ. It plays an important role in our dental curriculum. As I said, we have 18 so-called master clinics. And a master clinic is a unit in the student-run dental clinic for interprofessional practice learning for master dental students and for oral hygiene students. In that master clinic, the student develops the competences that are needed to become a licensed dentist or a licensed oral hygienist. And the student acquires these competences by performing so-called Entrustable Professional Activities. Epas. Epas operationalizes competence-based education, and it facilitates learning and guidance of learning in a clinical workplace. And in the lecture of Professor Olle and Cate, there's more explained about what an EPA is exactly. Here we see a diagram showing how the student dental clinic is organized. So we have 3 master clinics, they are clustered together. There's 1 teacher coordinator, and there's also 1 student coordinator. And this is also important because this student coordinator is responsible for organizing a lot of things around emergency cases, how students can help each other. So that student, that is a very important, has a very important role. In each master clinic, we have 4 dental students from M1, so the 4th year students, 4 of M2, and 4 of M3, together with 4 to 5 hygienists and 1 teacher. And as said, they treat 750 patients. And with the whole student-run dental clinic, we manage the oral health care for approximately 13,500 patients. It's also possible that students of the 4th, 5th, and 6th year, so M1, M2, and M3, they cluster together and they have a specialized teacher for specialized skills training. It's easy to organize because we have those clusters, and those clusters have practicum at the same time, and you can also divide them according to year. Besides the clinical work in the student-run clinic, we also have what we call academic clinical reasoning, and this is accompanying the clinical work. In this teaching module, in which, again, 4th, 5th, and 6th year students work together, the students acquire competences for evidence-guided practice. And the way how it works can be seen in the picture, where you see the 2 teachers sitting in the background, and the student is organizing and leading the session and doing a presentation. In this academic clinical reasoning, we make treatment plans, we train in making treatment plans, we have clinical lessons, we have evidence-based practice, we have guidelines for dental interventions, we work on interprofessional development, sometimes we cover ethical issues, and the students get a training in responsible referrals. Peer teaching and peer assessment is also important in this academic clinical reasoning. And we give seminars, teachers from outside sometimes come, and there are tutorials. The teaching tools in this academic clinical reasoning are team-based learning. We give lectures fitting to the level of the student. They work in groups of around 8 students sometimes, so we divide a cluster sometimes. And it's very much important, peer teaching, so the students have to prepare for that. As said, we work with EPAs in the student-run dental clinic. And why is that? It facilitates the learning process of the, let's say, modern student. It gives the responsibility for learning to the student, him or herself, so the student is responsible. It provides an opportunity for the development of a professional identity, and it helps to develop an attitude of lifelong learning. We think that it leads to competency-based education that merges with competency-based practice. And it supports monitoring and evaluation of the student progress for teacher and students. An entrustable professional activity is a professional activity that is entrusted to a student with sufficient competences and can be accomplished in a defined time frame. They are, as much as possible, defined as observational behavior. So a teacher or somebody else can see what is being done. And the descriptions of EPAs include both knowledge, skills, attitude, and behavior. Epas are part of daily clinical work. They're easy to recognize. In our student-run dental clinic, we have 14 EPAs for dental students. And here you see the list of EPAs we use. And the dentists among you can see that this almost covers the whole work of a dentist in the general practice. But I said that we have an interprofessional learning environment. So also oral hygienists are using EPAs, but not all of them. For all oral hygienists, we have 5, and you see them here in blue. The others, the ones in gray, are not in the package of an oral hygienist. And we share the rubrics. So we think that in diagnostics and in treatment planning and all the other EPAs you see here, that the rubrics and the level of the quality should be the same for oral hygiene students and for dental students. It's important to recognize that in the Netherlands, oral hygienists are allowed to treat primary caries lesions. And this is not the case in other countries, I know that, but in the Netherlands, it's allowed that they do that. So they have to meet the same level and the same quality as dentists do. I would like to close this short presentation with a movie, a short animated cartoon, which shows how we use the EPAs in our student-run dental clinic, excuse me. So I'm starting the movie now.
This is Emma, a 23-year-old dental student. She's now in the 2nd year of the Dental Master Program of the Radboud University, Nijmegen. Twice a week, Emma works in the SRDC, where most of the clinical work in the master curriculum takes place. At the start of the day in the SRDC, Emma and her team arrive in the SDC for the briefing. The briefing is chaired by one of the students. After the briefing, Emma chooses the EPA she's going to work on today. Here we see Emma treating her patient, supervised by an experienced supervisor. At the same time, about 10 fellow students treat their own patient, also supervised by the supervisor. Emma and the supervisor discuss the treatment of the patient, and the supervisor gives Emma feedback. At the end of the morning, Emma completes a digital EPA form. She reflects on technical aspects and professional behavior during the treatment of one particular patient. Emma sends her completed EPA form digitally to her supervisor. The supervisor opens the EPA form and reads the self-assessment of Emma. After that, Emma and the supervisor discuss the EPA form. The supervisor completes the EPA form with additional feedback. Here we see the self-assessment of Emma, including the feedback of her supervisor. The supervisor and Emma complete the EPA form and the supervisor closes the Scorion program. Using EPAs, students are gradually entrusted based on the work they have been showing in the past practicums and the trust supervisors give them for the future. During their years in the SRDC, students build up an extensive portfolio of EPAs, including self-assessment and assessments by supervisors. Both students and supervisors can see all EPA forms and feedback at any time. Here we see the so-called dashboard that gives an extensive overview of the portfolio of the students, both on group level and individual level. In total, after 3 years of participating in the SRDC, Emma has approximately 240 completed EPA forms in her portfolio. After 3 years in the master program and in the SRDC, Emma graduates. Her extensive portfolio now is a good starting point for the rest of her career, since she can use her past experiences to build onto and to become a lifelong learner. For more information, contact Radboud UMC University Medical Center, Dentistry.
Okay, so thank you very much, Nico. And I think we can, because Nico is now live with us, I don't know if people see Nico, I still see a movie, but I think we can take some questions if there are any. Let me see, Nico, you can turn on your microphone if you want to, and you can join us live.
Yes, I'm in now.
Okay, let me see if there is. I see some people who ask about the movie, but most of the problems seem to be solved. So we can take any questions if there is. Let me see, is there much time to take some questions? Yeah, we have a few minutes. I see one question about the integration of your programs. Let me see. Oh, someone asked why you chosen for 14 EPAs. Is there a specific reason for that?
Well, the reason is you can make EPAs or define EPAs at different levels, very specific for small parts of a total treatment or for a total treatment. And we decided not to go too much into detail. Other systems, they go very much into details because they want to evaluate also small steps in treatment. The fourth thing, so that was a choice on purpose for this undergraduate situation. In the EPAs, you still have some steps. We could not show that. Still some steps that can be assessed and where students and teachers can reflect on a more detailed level. But we didn't make separate EPAs about that. And the 14 is, I think, if you take that together, that's, well, covering all the work. A dentist who is just starting a practice where they need the competences for. So that's the reason why it ended up to become 14.
Okay. Thank you very much, Nico, for the answer. I have another question for you. Someone who said it looks like there's a lot of bureaucratic in this way of working. Is that, do you agree with?
Sorry.
Is there...
I'm sorry, that was here the question. Can you repeat?
I can repeat that. It looks like a bureaucratic system if you look at all the things you have to fill out. And is there a lot of workload to use such a system?
In the beginning, our teachers had the same feeling that, again, they had to fill out forms and things like that. But in this case, the most of the work is done by the students. And what we do is reflect on the reflection of the students. In our practicum, which takes 4 hours, we have half an hour at the end, because not all students are ready at the same time, where we talk with the students, have a look at the forms, and normally, I would say 90 or 95% of the times, everything is finished at the end of the practicum. So it's part of teaching, giving reflection. It's not only doing technical things. It's not giving education, not teaching. This is also part of teaching. And okay. The bureaucratic thing is very, I would say, not dominant, really not dominant. And now our teachers are very happy with it, and the students too.
Thank you, Nico. There was the second part of this question. Does it stimulate learning in its current configuration? And I assume then that it's yes.
Yes.
Thank you. I have to say that we are of course doing some research on that, and we will publish on that also with some data on how it is helping students in learning and how it's helping us in teaching. Okay, thank you. The last question I see, there is someone has a very practical question. If someone starts with pain diagnostic and then, for example, starts an endo, I believe that's EPA-6 if I remember, does the student change the EPA number? No, the student at the beginning of the practicum, the clinic, the student chooses the EPA he wants to complete and he wants to reflect on, and we don't change that. So the total of the EPAs, the 240, the students have to organize by themselves, and because they work in a group, patients are referred also sometimes. Each patient has a case manager, which is one student, who is responsible for the treatment planning and also for the progress of the treatment. And when the student is not ready for treatment because he doesn't have any expertise or competences to do that, then the patient will be referred to another student. But to go back to the question, at the beginning of the practicum, the student let the teacher know, this is the EPA I'm going to work on today. Although sometimes he does more things than just that one. Okay. Thank you very much, Nico. I'm very glad that despite the technical problems, we could still have you here in the live session. Like it sounded a little like you're on a train station. That was not your fault. You couldn't help that. It's well, that's a coincidence if you have to improvise. We make sure that we get a proper movie to all the participants maybe later, and we're gonna fix that. And all the listeners, well, I'm sorry for this inconvenience, but I hope you could understand. The slides were pretty clear, so that was good enough, I hope. Okay, so we go to the next presenter. Maybe a big hand for Nico. Thank you very much. And I'll do it. Maybe you hear mine. And all the other 120 people who are joining us, they are clapping for you at their homes. Nico, thank you very much. Normally I would give you a bottle of wine now or something else, but then we do that next time, another time. Okay, so I go to the presentation again. It was our next speaker, and I hope that you all can see the slides again. Our next speaker is Robert Smeenk. He is a colleague of mine, an educational scientist, and he's a specialist in innovation of medical education. He's very good in modeling and curriculum design, he's a lot of implementations done, a lot of experience in implementing the concepts of EPAs and programmatic assessment in the educational programs. And he's gonna take us on a tour through 15 years of innovation. What has he seen there? And for me, is it the question, is this the giant leap in education that we're all hoping for? I give a big hand for Robert, and he can
thank you, Roel.
Presentation. Yeah.
Thank you, Roel. So I will start my presentation. Thank you, Roel, and thank you, everyone. Thank you for attending this webinar. I will start with a short introduction of myself. So I'm Robert Smeenk. I've studied in Groningen, Master of Science of Educational Sciences, and I started working for Parantion in 2007. And with Roel, I'm one of the creators of the Scorion platform. And I designed and developed together with the universities more than 40 different medical e-portfolio systems. And during my study, I have graduated the design of competence-based education. And some of you recognize on the right side the 4 components instructional design model of van Merienboer and Kirchner. That's the picture. What we're going to do in the next 20 minutes. I would like you to take on a kind of time travel of 10 years medical portfolios, my educational experiences, and I will try to explain my experiences as far as possible with practical cases. So we can start. The first slide is before 2010, and what we see that are the most portfolios are still on paper and offline. And in medical education, such as medicine, you see every student has intern logbook on paper. For every internship, a new logbook. In these logbook are different kind of forms, and that are different specific assessment instrument for each situation. Now there are still a lot of forms in these logbooks, and there was less or no insight into the progress or feedback. And what we see is there was a delay on when you see the results in some kind of system. I want to show you some remarkable parts of the paper forms, and this is an example of a mini CEX. It's from University of Amsterdam. The content is in Dutch, but I will explain it in English. The first remarkable part is a Likert scale, and what you see there, the ample option is bold. And what we see is the paper forms manipulated the assessors to choose ample. This is the first remarkable part. The second remarkable part is what we see is there are text boxes in these forms, and in these text boxes they they ask different kind of questions. What went well, or what can be improved? And after that, it was difficult to find the specific data because it's all mixed up in the data in the system. And the last one, remarkable part is the 10-point scale. It's a scale from 1 till 10, but they don't want that the assessors choose the 1, the 2, or the 3, or the 10. This is what we see was a 4 till 9, but it was a 10-point scale. The next one, the 2010 till 2013. Now we see the first online portfolio systems with also online logbooks and forms, and mostly of these portfolios were a one-on-one copy of the paper versions. There's still a lot of forms. Every form was a specific instrument, and there was little cohesion between these instruments. And we made, on the right side, we made our first simplified quantitative dashboard based on smileys. And the last bullet, what we see, there was the university in Groningen, the study program dentistry. They asked us to design, together with the University of Groningen, a more holistic data-driven portfolio. As I will show you the concept, we make that together with the dentistry. And what you see here, there was a master in the dental care, 3-year of master, and in every master they educated different kind of courses. And in these in these courses there were a lot of low stake assessment forms, and every low stake they assessed on different kind of domains, and a domain is such a competence. And after a while, there was a formative assessment, a midterm assessment, and at the end there was a summative assessment or a high stake. And what we made for them with them is a system that was there were online forms in the system, and by example the midterm assessment form, there was a link to a report, and you can click on it, and then you see a dashboard with the low stake data. This was our first example of a data-driven, more holistic portfolio system. From 2014, what we see that was the content became more and more important. What we see, there was a lot of competence-based systems, and also the EPAs. And a lot of e-portfolio systems, they were based on the CanMed roles. You see also on the right in the graph that are the different CanMed roles. And what we also see, there was more and more training courses started with the programmatic assessment view. A lot of different assessment types, such as self-assessment, peer assessment, 360-degree, and OSCE. And we made together with the university the first dashboards to show the progress of the students. Now I will show you some different kind of assessment types. The first one I want to show you is the self-assessment. And what you see there there were online forms in the systems, and the students fills out these forms by herself. And so as the data, you can see the student was the sender and also the receiver of these data. The next one is assessment by the supervisor, and the students sent a form to a supervisor, and the supervisor fills out these forms, and so she was the sender and the student was also the receiver of the data. The third one is the example of what Professor Creugers said. That was an assessment form. There was a pre-fill option for the student. The students pre-fill this assessment forms and then send it to the assessor. The assessor receives a filled out form and then completes and improves these kind of forms. The next one, that was the 360-degree forms. In these forms, the students receive feedback from different kind of roles, such as a supervisor, peer, and coach, and it contains also a self-assessment in these kind of forms. And the last one I want to tell you, there was a OSCE kind of assessing, and what we see there's the students has a lot of assessment stations, station 1, 2, and 3, and every time the assessor fills out an online form in the system. So I want to show you two examples of our first dashboards in the system. The first one is the dashboard from Sydney, from Macquarie University, and what we see there were various assessment tasks, and every task assesses on the different CanMET roles, and also the capability aspects. There's a 1.1 and a 1.2. That's the capability aspects, and the scientist and scholar. That's an example of the CanMET role. And what you see there, every capability aspect has its own grades, and the red one is the fail, and the dark green one is a pass plus. This is an example. The next example is the example of the dentistry from the Radboud UMC from Mr. Professor Creugers. And what you see there was a graph with the averages on the different EPAs, the EPA 1 till EPA 14. And what you see there was an not on track, an on track, and a fast on track. And the dark blue line is the scores of the students, the feedback scores on the student, and the light blue line is the average of the peers in their cohort. And what we did there was the progress through the time, and also the narrative feedback. In recent years, we have seen more and more portfolios with multiple content dimensions. As what we see, there is a system with competences and EPAs, or with learning outcomes and learning goals. And when we start together with the universities to design a portfolio, we start with to think about how the dashboards look like. As we start with the design of the dashboard, and after that we design with the universities the assessment forms and the assessment types. And what you see there are multi-dashboard views in the systems, such as competences, EPAs, or goals. And the last one is what you see there is a more and more mobile use of mobile devices. This is an example of a dashboard of the University of Applied Sciences in Utrecht, the study nurse practitioner. And what you see here is in Dutch, but this is a multi-dashboard view. The first one is the competence view on the CanMET roles. The second one is the quantitative and the qualitative progress. The quantitative progress is you see the filled forms in the system, and the qualitative progress, what you can see there is if you pass a test or something. And the third one is also they show the EPAs, the progress on the EPAs. My last slide in this presentation is the more and more mobile slides. What we see there is more and more use of mobile devices, and our latest innovation is voice recognition. And you can speak to the app, and the voice goes to data, to text, from voice to text. And yeah, there's a lot of use of mobile mobiles and tablets. So that was my last slide, Roel.
I will turn on my microphone again.
Yes.
So thank you very much, Robert. You explained me before your presentation that you was afraid that people couldn't understand your English with little Dutch.
Language, yes.
I think it was very clear. I even turned the sound a little lower, so I think you were very good to understand. Very, and you asked me if I would summarize your presentation. Well, what I and I had to use your own model for that, and what you just told us. And what you actually see is that there is an innovative change in education based on these three axes or triangles. In the first place, what we see in the last, 10, 15 years is that the educational content actually is changing very much, and the EPAs or APTs for our German colleagues, but also the competences. So you see that on one hand, the educational content is changing. On the right side, the orange triangle, you see that the ways of giving feedback are changing as well. What we used to do is just give grades, and now we have all kinds of different ways to assess people with feedback or rubrics or whatever. And the third part is the blue one, is that also the technology drives us to new insights, and we are in the beginning, I guess, because all these data, all the text we gather now will also be analyzed as data. So we can expect a lot more of all these innovations. Let me see if there is any questions. I see some questions. So the first presentation from Nico was very practical, how it works in the... Oh, there is Robert. Oh, he's joining me. So now you can see him again. There was actually a question about the app where you speak this data, Robert.
Yes.
Is it very easy? How does it work with this app where you can speak the data in? Does it also can be analyzed in the tool?
Yes. In the tool, you can make your own forms as a university. And if the forms contains a text box, you can speak it into your telephone or tablet, and when you speak, the voice goes to the data, and the data is analyzed in the system. Yes.
Okay, thank you. I see another question. How long does it take to implement a proper education?
Normally, the implementation is between 3 or 6 months, and 3 months is the small ones with whereas everything is clear, and 6 months is more regular. The implementation, I think the first month, the first 6 weeks or something, we discuss with the university how they would assess the competence of the EPAs and what kind of assessment types they will use. and after that, in the month 3 or 4, we built this system, and then we do a pilot and testing, and then you can go live.
Okay. Let me see, because I'm reading in the timeline, which if there is any more questions. Let me see. I see some questions about people who cannot see the movie, but I think let me see, which part of an implementation is the most difficult one?
I think our implementation has different parts. The first one is to design and to think about the system, the curriculum, and I think that is the most difficult one. Is the same together with the universities. You think what kind of assessment types, what kind of forms, what kind of variables, and how does like the dashboards. I think that's the most difficult one. Yes.
Okay. Okay. Thank you. Let me see. I go to the Q&A side in the presentation. Does it matter for you if a system has 14 EPAs or 20 or 2000?
No, technically not. But if you use more than 20 EPAs or something, it's very specific. And when we make a dashboard or something, you have a lot of dashboard views. Because mostly it's between 6 or 15 EPAs or competences to show it on the graphs and that kind of things. Okay, thank you. Let me see, there is a question and also a remark that is from Bart. He said, I like your integral model. It challenges us on how to air data between application, as there is no one-size-fits-all solution. How does Parantion see the interoperability, sorry for the, now and in the near future? So how do we connect all these different kind of data? It's a very good question also. How do we connect all these data to each other? Roel, that's a difficult question. You can maybe, you're from the model. No.
Well, interoperability is no, but that is a problem, not only for systems, I guess. It's also a problem because the different kind of the different curricula don't fit to each other. That's why I think Nico can tell us about that. But you see that the dentistry educations in the Netherlands are working together now to one kind of curriculum with all the same EPAs, and then it will be much easier to connect all these data, because the system is not the problem, it is the difference between all the curriculum. We also have questions from, can someone take his portfolio or her portfolio from, let's say, Amsterdam to Groningen if you study medicine? Well, that's at this part, it's not a problem because of the system, it is because of the curricula are completely different. So what we do then is make a zip file from all the forms, and you can take that with you to your next education. But it's more, there's no real standard for portfolios, only on the basic data. So
and we have integration with other systems, such as testing systems or something. In the Netherlands, you have a progress test, and we import these data. You can show this data from the other system on the dashboard.
Let me see. Is there any new questions? And otherwise, we can go to the presentation of Professor Cate. Thank you, Robert. Are you you're leaving us?
Thank you.
Okay. Okay, I'll start. We go over to the next part of this we have. I think I'm going to introduce our next speaker, if that's okay. Let me see if there's nobody objecting. Let me see. I see that Professor Cate is ready. Okay, I'll introduce Professor Cate. And actually, he doesn't need any introduction, I guess, because that's why I call it an informal introduction, because if I tell everything Professor Cate did, then we are at the end of our day, I guess. But he is the founder and director of the Center for Research and Development of Education at the University Medical Center in Utrecht. His research interests are curriculum development, peer teaching, competency-based medical education, and many other topics. And he is actually the founding father of the Entrustable Professional Activities. Let me see if there is, at this moment, I think this is enough for right now. He'll probably introduce himself a little more, but maybe he doesn't need any introduction. I'll give you a warm welcome, Mr. Professor Olle Cate. And you can start your presentation now.
So, yeah. Am I?
Yes, I can see you loud and clear, and if you share the presentation.
I will, yes, I will. So can you see my presentation at this moment? Yeah. Oh, thank you very much for the introduction. I had a very small comment in between whether I just wondered whether people need a restroom break since we have a minute. So would you advise people to take a restroom break before we start? Yes?
You can do that.
Just 1 minute and then be back?
And like, it's a good idea, very good idea. I think people are moving on their chair, so we let's have a 1 minute break, people, and then we'll get back to you. Very good, Olle. Thank you.
Sure, I'll use that break too. Yeah. Okay, can you hear me still? Okay, so I'll just wait for a sign that you would say start, okay? Now?
I think, Professor Cate, I think that we can start. Everyone has been to the restroom for for their convenience. So I would say let's go.
Sure. Well, thank you again for the invitation. I'm delighted I'm always delighted to talk about EPAs. So I'd like to take you for about half an hour, I think, through some fundamentals of Untrustable Professional Activities and entrustment decision making. My name is Olle and Cate. I'm from the Center of Research and Development of Education. And just to add to what Roel just said, I recently stepped down as the director, but I'm still a senior scientist at the center. And that's located at University Medical Center Utrecht in the Netherlands. Now I see I have to move my slides. Yes. So I will be talking to you about competency-based medical education, about its purpose and its practice, about the inherent difficulties of workplace-based assessment that we all face in clinical education. Then talk about EPAs, what are EPAs and why may they be a solution to our inherent problems of difficulties of workplace-based assessment. Talk a little more about the nature of EPAs and the levels of supervision. A little bit about prospective rating, I'll explain that word, and the qualities that affect entrustment decisions. And I'll end with a small wrap-up. My focus will be largely on medical training, but you can just translate that to any health professions type of education, and also to maybe even to other domains. So let's start thinking about what is the ultimate goal of medical training. And you could phrase that as expecting that physicians and residents and specialists that we graduate can be trusted to provide high quality and safe care. And that is something that sounds easy, but it's not so easy actually. Who can be trusted to do what? Let's turn to something that is linked to the idea of entrustment as the level of supervision that you need. Now, if you would look at what the Netherlands say in their medical act, their legislation, so the Dutch Medical Act actually says that all doctors are entitled to perform medical tasks. All those who have an MD degree and are licensed and took the oath are actually entitled to perform medical tasks in their breath. But in practice, they will not be allowed to do that because what is added is provided that they are competent. So what does that mean? What is competence? That's the big question then. What is competent and how do we know that people are competent? Just imagine you are a program director and you are at the point of graduating one or more trainees at the end of specialty training. An important question that you could ask yourself is, would you trust your own family members as patients for those who you are graduating? We're actually doing a study at this moment, and we recently published some of that in the British Journal of Anesthesia, that we found in interview studies that many residency program directors can recollect cases signing off themselves for completion of training, even if they were not confident about the level of their trainee at graduation. So why is that? Why do people have difficulty do that? Why does it happen? You can call that failure to fail. So it is you cannot easily stop students sometimes, because one of the reasons could be just the time is up. You have a 4-year program or a 5-year program, a 6-year program, and it's just at the end of the program. I mean, it's July 1 or any other date in the year, and that's the time to graduate. So you're graduating people, even though you sometimes may not be confident. Or you would say, we don't have any valid documentation to back up any failure. We know that people don't meet the bar, but we just can't, we don't have the evidence to show that. And if they would make a case against us, they would probably win. Or you would say, well, if you would fail a trainee, that would give yourself trouble, because there's a whole hassle going on if you would fail a trainee. So rather not do that. Or you could say that we don't just have the tools to handle this. Or some people would say when we are unsure, we probably rather err at the benefit of the trainee. So give them the benefit of the doubt. But at the same time, you have to realize you're not giving the benefit of the doubt for the patient. So you could say the imperative of competency-based medical education is to reduce false positive decisions when graduating trainees for unsupervised practice. Competency-based medical education was first described in 1978 in a document was written for the WHO. And for some decades, you didn't hear much about competency-based medical education until about the turn of the millennium, when the Canadians presented their CanMeds framework and the United States came with their Accreditation Council for Graduate Medical Education Outcome Project, and the United Kingdom came with Tomorrow's Doctors. So why was that? There was a general dissatisfaction felt with the quality of care in hospitals. Patient safety was an issue, but also dissatisfaction with training models, with the supervision. There was not much structure in clinical training at all, actually, in the until the 1980s, 90s. So here's where they suddenly important documents were published and that were used in several countries. And those who are in different countries will recognize their own system. The Netherlands has adopted the CanMeds model. Now, the essence of competency-based medical education is actually that education should aim at a standard level of proficiency for all the graduates. And critical features then are a clear description of those standards. So we want to know and want to define what is a good physician or a specialist. We need to assess all medical trainees using these standards, which actually means that if we acknowledge that trainees are not identical, that their competence should be actually the criterion and not the time in training as a primary reason to finalize training. Here's an example. Look at these data. These data are actually from a progress test that is being taken among the Dutch radiology residents. And these data are across a number of years and across also different stages of training, from postgraduate year 1 to postgraduate year 5. And you could actually see that people actually increase. It's a comprehensive test across all of radiology, and every resident should actually, it's a mandatory test. They all take that test. But what not was until recently, what the radiologists did not do is set a bar that everybody would have to pass the test. Now they did that. They now say we are moving to competency-based medical education. So what we are defining, this is the minimum level that every resident should pass. And it's not a very high level. It's really doable for all residents, but it's critical specifically for this group. This is a group at risk. We no longer accept these people to graduate in radiology because they have not met that threshold level that we would call for a competent physician. So competency-based medical education has the principles and has practice. And principles are embraced in many countries. People like this principle and say, well, this is the direction we should move to. In practice, there is sometimes some criticism. I can show what happens if you move to competency-based education and are very elaborate in describing the competencies. Here's an example. The CanMeds model has seen many generations. The most recent generation is about 5 years old, and now has very elaborate descriptions. It has 7 roles, and 7 roles is something that people be able to remember and can think of when you evaluate trainees. But there's also many key concepts, many key competencies, enabling competencies, milestones, many things. And it's not easy to use all those elements. Even if you would only have the 7 roles, just imagine you are a clinical educator, clinical teacher, and you have an intern who does a rotation with your department. And the question is, please rate this intern at the end of your rotation on 7 domains of competence. Only 7 domains. We're not talking about 700 elements. And we have the same 10-point scale that was just mentioned in a previous presentation, from 1 to 10, and from extremely low to exceptionally high. Just imagine you are forced to give a score. And you just imagine it is very, very hard to get that score because there's so many things you don't know. You have only a limited view of this resident. So this, you can just imagine filling out forms that look like this is not going to be very reliable. And some years ago, Stefan Luhrer and his colleagues published a paper in Academic Medicine. And what they concluded on the measurement of general competencies is that there's no evidence that the current measurement tools can assess competencies independently. So we need further efforts. Actually, they are even unlikely to be successful. So their advice is use competencies to guide and coordinate evaluation rather than develop instruments to measure competencies directly. Yet, measuring competencies is what most programs still continue to do. And you will encounter issues in workplace-based assessment doing that. There is, based on the literature, you know, there is something like generosity error. People give too high scores on average, which also relates to the failure to fail phenomenon. Then there's a halo effect. You have only a very small observation, and you're tending to generalize from one observation to a whole holistic picture of the person. There's a lack of reliability. Just there's no reproducibility of scores across occasions or across raters. There's very often unclear standards, or very often people don't even have a standard in mind when they have to make a score. And we know that observers and raters differ in how they observe and they rate. And ratings are unclearly related to either proficiency. You could say, well, this trainee is a very good trainee, so proficiency is high, give high score. Or personal development, you would say, I see where they come from, so they develop so much they deserve a high score. Or to effort, you say this is not a terrific student, but I can see they have spent so much effort. I want to actually award them for the effort. Or you would say, well, this person is not perfect, but the reference group of other trainees have been scoring so highly, I can't stay behind for this one learner. So why is competence assessing competence so difficult in the workplace? Just imagine this. Imagine you are a clinical teacher. Your school and your educational program director asks you to observe a learner, to provide feedback, and to report a score for that student. Now, imagine, just close your eyes or open, keep open, whatever, and you are observing a student, and pause and analyze your own thinking. You will probably recollect cases that you find it not very easy. So I'll think along with you. So was the student prepared? Was the case easy or difficult? So what actually does a perfect task execution look like? Or maybe you found this performance pretty weak, but how can you say that to the student without hurting their feelings too much? And you have to realize tomorrow you'll have to work with that same student, so you won't interfere with your working relationship. And so what actually is a reasonable score on a 5-point scale for this pretty weak student? Would it be a 5 or a 6 or a 7? And since you have to work with that student tomorrow too, you'll like the student, and You maybe have been the only observer in this afternoon. Nobody actually knows what is going on in your mind. So maybe could you give a 7? Well, your heart actually says no, it should be a 5, but then that gives you difficult. Well, all these kinds of difficult psychological things go through your mind. So the psychology of traditional workplace-based assessment is pretty difficult, and you know the learner actually hopes to receive a superior mark, and in your mind you're thinking she is a nice person, she works hard, it will not hurt her, and it will probably motivate her if I mark her as superior. So we're not really satisfied with these processes. So what is needed? So we would actually like to have assessments that more matches clinicians thinking in clinical healthcare and training for entrustment with critical activities in healthcare. We'd like to preferably give a holistic and not a tick box approach. We'd like to have integration and not separation of various competencies. And at the same time, you want to do something that's practically feasible. Jim Crossley and his colleagues about 10 years ago published an important paper that was called Good Questions, Good Answers. So what you'd like to get, if you want reliable answers, you must align the construct of patient care with assessment. And that could make assessment skills more reliable. This is an example of such an approach. Just imagine you are a clinical teacher and an anesthesia department, and you are looking at residents and looking after residents. The single most important question that you have every day is, can I leave the operation theater or can I not leave it? And if you use that in your assessment approach, it's not whether you're like the student or not like the student. Can you leave the operation theater? Is it safe to do that? Can you leave your resident alone with the surgeons and with the patient? Using that scale actually improves reliability of assessment. So it's a different approach, and it's a different approach that really links to entrustment. So entrustable professional activities, this is one of the reasons to start using that. And some, such as the surgeons and many other specialties, have found that the idea of entrustment and entrustable professional activities might be the way to go for the future. So to rehearse with you the definition of EPAs, an entrustable professional activity is a unit of professional practice. You can think of it as a task that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute the activity unsupervised. The purpose for using EPAs is to operationalize competency-based medical education through a stepwise and safe engagement of trainees in clinical practice with a progressive autonomy. And to becoming competent can be defined as passing a threshold that allows for sufficient trust in the trainee to act unsupervised. So why would we use EPAs? So we have that threshold, and that's the MD license for specialty registration, but it's far too broad. We cannot oversee that. For any single educator cannot oversee that. And EPAs break that down into its breadth breaks down in units of practice that can be overseen, assessed, monitored, documented, and certified. It could be like 14 EPAs for dentistry, for instance. It's a reasonable number. Competencies are often felt too remote from clinical duties to be optimal for assessments. They are very often felt as rather theoretical. And EPAs is just the work that must be done tomorrow or the day after tomorrow. That is something that you can assign to someone, and they are a better focus for assessment. A regular assessment is not directly linked to the progression of responsibility. You give a score and then everything is the same still afterwards. Entrustment decisions, however, for EPAs are a deliberately linked to progression of responsibility. So Entrustable, again, is acts that requires trust, and could be by colleagues, by a program director, by a clinical teacher, by patients, by the public in general. It is professional. An EPA would only be an EPA if it's confined to an occupation with an extraordinary qualification and right. So you're bestowing that right on an individual because they have shown that they can do that. And it's an activity. It's not a competency. It's an activity. It's a task that must be done. But EPAs can ground competencies in daily practice. So again, if you look at the difference between competencies and EPAs, competencies are clearly person descriptors. They describe a person in their knowledge, their skills, their attitudes, their values, their abilities, their scholarly skills, whatever. So a competency, if you look at Oxford Dictionary, is the ability to do something successfully or efficiently. And EPAs, however, are work descriptors. They're outside the person. They're not part of the person. They don't describe any person. They describe the work. They're essential units of practice. A patient must be discharged, must be counseled, family leading must be led, a treatment plan must be designed, patient must be resuscitated. So if you have a competency, is the ability to do something, that's the EPA. It is just something that is trusted to be done successfully or efficiently. So if you have a clinical department, there's many tasks that must be done, and you want to assign them to people that actually can do that, or have the right profile to do that. If you don't have those persons, you have to hire them, or see that you have the persons available, or maybe train them to have the right profile. If you have a surge of COVID-19 in your ICUs, you're looking around to have the people with the best profile to help you, or you have to train them and instruct them, get them an EPA in attending patients with COVID-19 on the ICU. So if you look at EPAs and competencies again, it's 2 dimensions of a grid. But there's hardly any EPA, any task in healthcare that you can imagine that does not draw on several competencies domains at one time. Even history taking, you say, well, you need communication skills, of course. But if you have no idea of professionalism, or no idea of health advocacy, or specifically medical expertise, you may not be able to ask the next question because your clinical reasoning is dominant in your history taking. So, and that holds for any EPA you can think of in healthcare. So if you assess learners, please assess them based on EPAs. That are the things that at the end of the day, you must graduate people because they can do the work. And whether they have the competencies, that's fine to know. But you actually, if they satisfactorily can do all those EPAs, you can just infer that they will have those competencies. So in that sense, working with EPAs is actually building a holistic framework, because all those competencies, competency domains actually are integrated in the evaluation of an EPA. So why do EPAs then change workplace-based assessment? The core question of assessment for entrustment is not so much to determine the point on a scale of proficiency that matches the learner best, which is the traditional approach to assessment. But here it is considering a decision to increase the autonomy of the learner. So if we would go back and define competent, you could actually define that very easily by saying that when a professional activity is mastered at a threshold level that permits trust to act unsupervised. So competent then is a stage in a developmental continuum. And that continuum could look like this. There's growth of competence. If you superimpose that on a framework of development, and this is a well-known framework that was published about 30 years ago by Dreyfus, and they distinguish 5 stages of development, which is novice, advanced beginner, competent, being proficient, being an expert. And the nice thing is they use the word competent in the middle of their skill. And here's where we would define, after a training period, this person has passed a threshold of readiness for unsupervised practice. We trust that person to be ready to do that, and that could be defined as our training period for that EPA, for instance, because this graph could represent an EPA. Another EPA might be easier. Or another EPA, you started training only in the second year of training. This is a very easy EPA, but if you could draw that same line, the threshold of being competent, you could easily see that there could be different moments during the training period that you could actually make that decision, a justified entrustment decision that people can work on their own. They don't need supervision. That does not necessarily all happen on the last day of training. You could do that for some earlier. There could also be an EPA that you actually have established, that you know that people have passed a threshold level. But after training, if they never practice, they don't continue with deliberate professional practice, they will not increase, may even decrease in their competence. And if it's a very critical activity, maybe after a while, you should lose the trust of any educator, or maybe the trust of the public and the patients to do that EPA. So you should think of that too. So we've talked about supervised or unsupervised practice, but there's a more detailed scale. And we usually use 5 levels of supervision, reflecting an increasing trust in the level of the trainee's autonomy. So we start, of course, at allowing the learner to be present in the healthcare environment, but not permit them to enact an EPA. The second level would be to have them practice with direct proactive supervision of a supervisor in the room. The third level would be to practice that EPA with indirect supervision, reactive supervision, that the supervisor would not be in the room, but would be readily available if the learner needs help. It's a significant next step, because between 2 and 3, it's very important to understand that the learner will acknowledge that they actually need help and that they will actually do that. And level 4 then would pass that threshold for unsupervised practice. And if you're still in a training period, because you're formally still a trainee, of course there will be distant oversight and or supervision at a distance. But basically that's the level that you would expect people before they go to unsupervised practice. They have to have that level. And if you are even more proficient, you might act as a supervisor for more junior learners. So if you think of it, this could lead to an individualized workplace curriculum. Just imagine you have a learner with a portfolio, and the portfolio could look like this. You have 4 EPAs, there's 4 years in your postgraduate training, and that learner actually progresses for each EPAs through all those stages of 1, 2, 3, 4, 5. And you could easily see that level 4, which is actually the minimum benchmark level for completing the training, could be for different EPAs at different moments in time. And for some EPAs like EPA-C, there could be an early one that you could start being a supervisor for junior learners. And just imagine this is an individual portfolio for trainee Jones. For another trainee, there might be a template of expectations that looks like this, but in practice, those decisions to have people do things on their own unsupervised, the decisions for level 4 could be at different moments. So that could be individualized. Now, an important way to think about this is the distinction between retrospective evaluation and prospective evaluation. All those people who are educators, and many of you, I hope who are listening, are educators. And basically in education, what we usually do is we give assignments to students. It could be preparing for a test that we take, or giving an assignment to do something in practice. And when the student actually does that assignment, they get a high mark. And you could say, well, if you have done show mastery, everything that we asked you to do, and mastered the content taught in courses and rotations, we'll sign you off at the end of training that you have passed all those hurdles to be graduating. Now that's a prospective perspective on assessment. Oh, that's a retrospective perspective. The prospective perspective is different. The prospective perspective asks the question, is this student ready to assume the expected future responsibility? So why is that a different question? The difference is because even in rotations, even if you have frequent observations, you are sure that you will not be able to observe everything that's necessary. And you are graduating people in healthcare to do things that you may not have been able to supervise. And even the trainee may not even have encountered. So if you go back to the psychology of EPA-based workplace assessment, you have the same student, please mark me as superior. So now your thinking is, if I mark her in an entrustment decision, you could think, well, she's nice and she works hard, but it may hurt my patients if I mark her ready for unsupervised practice. So that may withhold you to give a too high mark at a too early stage. So the trust concept in EPA-based assessment is really linked to this whole idea. So trusting someone is making yourself vulnerable. If you take that decision that the student is ready, you will transfer your own patients actually and give them in the hands of your learner. So you take a calculated risk that any adverse events are acceptable, can be solved if you need it. And graduates, you have to realize, will be certified to carry out activities that you have not, as a supervisor, ever been able to observe. And learners may have never even encountered those. It could be rare instances, but if you take that trust decision and entrustment decision, you actually take that decision, and that's looking prospectively. So that gives a different flavor to your whole assessment approach. So entrustment decisions require some sort of estimation of adaptive competence to cope with unfamiliar situations. And if you do that, trust can boost confidence and motivation. If you really say to someone, I'm not giving you a high score. I know learners who get a high score at the end of a rotation, and then they would say to me, I don't know whether I can trust that, because they do that with every student. But if you would hear a person say, well, now I'm ready to have my own family members, have you take care of those, that is really a true sign of confidence in you, and it can boost your self-confidence. Now, if we think of entrustment decisions, we should make that difference between ad hoc decisions and summative decisions. So ad hoc decisions are those decisions that you take every day as a clinician in daily practice. You will evaluate them. And after a while, if you've seen that enough, you would have persons actually go for a summative entrustment decision. That is more of a formal statement, a statement of awarded responsibility based on multiple workplace-based assessment and focus on increased autonomy. Sometimes we call that a STAR, that statement of awarded responsibility for a specific EPA. And the flow of workplace-based assessment data that you could use with a portfolio, it looks like that. Here is an EPA and a learner. There's multiple times that this EPA is being done by that learner, and every time there is an observation, the one who observes and preferably using mobile devices to actually efficiently do that, that evaluation is being done, and actually the result is actually transferred to a portfolio. And in the evaluation and feedback to the learner leads to a better performance the next time for that EPA. And if that EPA has done sufficiently and at a high level, the learner may be ready for a summative entrustment decision. So what happens then is either the learner requests that, or a supervisor might suggest that to a clinical competency committee, or sometimes called an entrustment committee, that receives and evaluates that request and draws on the information from a portfolio. And if they decide that is justified, given all the data that we have, then they can take that summative entrustment decision. From now on, we allow you to work with only indirect supervision or only even unsupervised. And there's many factors that actually are involved in those decisions. Just this is an ad hoc situation. And just imagine this supervisor thinks about that student. Shall I trust this student to attend to this patient now? And that's an ad hoc decision. And it has many components. So I trust this student to attend to this patient now. So that's about a trainee, this student. As supervisor, I'm the supervisor, but I may be different in my evaluation than another supervisor. What is the task? What is attending to this patient? What does it actually mean? Is that a critical task or not? This patient is also part of the context. Could be a different patient, and I might not ask them to do that, or do it now. That's different during the day maybe than in a night shift or in the weekend. So there's many things that actually come into that equation. And this is just to show that there's so many things that you could think of. Well, just focus on one thing, that is the trainee features on the left upper side. So if you go to those general qualities of a trainee that are important when you consider entrustment decisions, and we've actually, if you look at the literature, and we actually have a publication that will appear really soon, probably next week or the week after. And we have found actually that what people value, what clinicians value, is capability, which is knowledge, skills, experience, awareness, and oversight specifically for that task. Integrity is truthfulness, good intentions, patient-centeredness. Reliability is to be conscientious, to be predictable, have predictable behavior, to be accountable, responsible. Humility is this person observing their own limits? Are they willing to ask for help? Are they receptive to feedback? And finally, agency is important. Is this person sufficiently self-confident? Are they proactive towards their work, their team, their safety, their personal development? If you juggle the first letters around of these 5 elements, you come to the acronym of a RICH. So think of a rich entrustment decision. So to wrap up in this last slide, justified entrustment of trainees with responsibility is the core mission of education, competency-based medical education or other education too. And the analytical competency-based education needs actually EPAs, the more holistic synthetic approach to connect with clinical practice. Why? Because EPAs break down the breadth of a license into units of practice that we can well overseen, assessed, monitored, documented, and certified. And entrustment decisions making in assessment is more than the evaluation of skill and knowledge. And a rich entrustment decision reviews the learner's agency, reliability, integrity, capability, and humility. A traditional workplace-based assessment looks back at how a learner did. Entrustment decisions, however, look forward to future competence. So I thank you for your attention.
Thank you very much.
And how do I stop share screening? Okay, here I go.
I'll just take over, Professor Cate. Yeah, I just take over. Let me see. I have a final slide. And that's actually this one. After this, I have one more. Thank you very much for the very interesting presentation, very inspiring. And I have seen that there is a lot of questions. I thought about that before. So I put some of the questions already in the timeline of the published one. Let me see. And I promised these the people who asked these questions that we're gonna answer them in the Q&A. I don't know if you can see them all, but I can read them for Can everyone see these questions? I guess, yes. The first one is when can we really say that a student is qualified in an EPA? Is there a certain number of times that an EPA has to be carried out? I think it's a question for you, Professor Olle and Cate.
Yeah, that's an excellent question. So I can tell you there's a huge variation in doing that. So for every EPA, if you are a curriculum committee or an examination committee, you have to sit down and think thoughtfully about the EPA. And as Professor Creugers also said, well, you could have EPAs that are small, that are large. I can give you an example of if you would want to make sure at the very most junior learner that you can just imagine in healthcare is measuring blood pressure. And that could be a very small EPA. I would not recommend that for any higher level. But actually, if you would say to a student, I trust you to do that because we're not going to check that blood pressure anymore. We just accept what you report back to us. You can imagine if you just see that once or twice and see that people do that very well, that could be enough. So if you are a fellow of gastroenterology, you are learning for colonoscopies. We know that people have supervised colonoscopies about 250 times before they would even consider to be allowed to do that on their own. So that's 250. So that is huge numbers. And of course, you would not even start to consider that on an early stage. But the lesson really is that you have to, with your curriculum committee or whoever decides about that, make thoughtful thoughts about that. And there's just one thing. If you just define a number only, if you say, well, this is an EPA, and if we observe that 4 times, that will be enough, just realize that if you, the third and the 4th time, you would find that's not adequately done, you would have to see that more often, because you cannot sign off only just because of the number. You would have to see that because, and you could say, well, we need 5 observations, but after 3 observations that were all terrific, you might even make the decision in this case, we don't need the other 2 because we now trust this person. So trust is something that combines many, many things. If people show very stable behavior, then it's more easy actually to make that entrustment decision. If they show very unstable behavior, because sometimes they're doing well, sometimes they're not doing well. I know one of my colleagues, Carrie Chen, has a very nice slide. She shows like 15 observations of one EPA of one learner. And you could say this, on average, learner A does actually a better job than learner B. But if you look at the individual observations, you can see learner B has never been below a threshold level, whereas learner A actually shows some really bad times, maybe for whatever reasons. She does terrific on some other cases, but it's unpredictable. So that makes a difference in practice. So I would recommend for EPAs just to sit down, write that up and say, this is our general benchmark for the number, but then for the learners in practice, make a deliberate choice per learner or 2. And just also say to the learner, we're not guaranteeing that 4 will be enough. It might need 5, and sometimes maybe 3.
Okay. Thank you very much, Mr. Cate. I think it's a clear answer, although it doesn't make it really easier, of course. But I don't think, and that's the next question, I don't think EPAs are easy, is it? The next question is, does it cost a lot of change and effort by the staff instead of a traditional EPA, a traditional curriculum or an EPA-based curriculum? Is there a big difference?
So what I can tell you is that usually changing a curriculum in medicine, it takes a lot of effort anyway. But what we found in practice that if you start talking with your clinicians about EPAs, what are the things that are important? We find usually that clinicians understand that very well. They can think more easily in units of practice like EPAs than in more theoretical scaling of competencies and do that. I can tell you that just yesterday I had another conversation with a colleague in Pennsylvania, and he said, since we're using EPAs instead of the more focus on EPAs than on the milestones that are in the ACGME framework, the clinicians can much easier do that. Now, what is important, and that's the caveat, in using a skill that is focused on entrustment, that is something that people have to really understand, because that's not a habit that people have. Usually people say, it's easy to look at someone and just say, did they make any mistakes? No, they didn't, so I can give a high score, they didn't make a mistake. But the question really is, and that is what the training requires for faculty development, is that you want people to think about more deeply about that trainee. Is this trainee ready to decrease your supervision? Which is a different question that they make no mistakes now. Mm-hmm. So I would say there's two sides of that coin. So working with EPAs is pretty intuitive, and people like that. And most people have no difficulty to move in a curriculum using that. Using a skill that draws on entrustment decision making that requires effort, but people understand it, but it's a different view on assessment.
Yeah, okay. Thank you very much. We have the last question because our time is almost up, and but this question I want to park for just a few seconds, because I would like to go to Mr. Professor Creugers. Maybe can you tell something about the change in your curriculum from, let's say, the old school curriculum to your EPA? Was it a complex process?
To turn my...
Yeah.
Well, as Professor ten Cate said, changing a curriculum is always a huge task, a huge and complex thing, and so you have to prepare that very well. And if you go to introducing something like EPAs, you have to inform the people and also find out that the people stay behind using that. And in the beginning, it needs also a lot of, let's say, talking between the members of the group, because we also have to learn how to work with the EPAs. That's a very important thing. What we did with our curriculum change for the master is we changed 3 years at one time. So it was a huge operation. And but there was also no escape anymore. And what is important is that we supported and supervised all our teachers in performing their job in using EPAs. Okay. So yes, not easy, but very much rewarding.
Not easy, but doable.
Not easy, doable, and rewarding.
Okay, yeah, thank you. It's a good summary. Thank you very much. And for the last question, I go back to Professor ten Cate. Isn't it getting very subjective? And you know, we were in China with a project where they wanted to use EPAs, and they wanted to use the feedback as and students who could give themselves scores, and they said that's not going to work in China because people are cheating all the time. So and that was China, but here the question is based on trust, subjective. How is that, Professor ten Cate?
Yeah, that's also a very good question. I can talk about half an hour about that. I published a paper in Academic Medicine last year on subjectivity, the power of subjectivity in workplace-based assessment. And maybe one lesson from that is we can work with scores that look like, because they're on a scoring form, and you could suggest that as very objective because everybody has the same scoring form and you have to score that. But you have to realize that the important decisions based actually from your observations, many things you cannot actually put on that score. So when we suggest that we have very objective scoring and assessment approaches, what we're losing is the very rich impressions you have. If you know a learner very well, you know a learner in many respects. And I tried on a few of these slides, I tried to summarize all these elements. They are so important, but you lose all that information if you use very simple scores. Now, I agree with you that it will not be easy to suggest to the outside world that these entrustment decisions are very important if you cannot document that well. So one of the things that is important is that, as I said, ad hoc decisions can maybe just by individual teachers. The important summative entrustment decisions must be taken by a team, must be based on as much information as you can get. Some people call that programmatic assessment, with combining multiple data points to come to a decision, and also as a team. And if you are a team, then if your decision to graduate a student because you have seen that they've done well, and that would be challenged by a jury for whatever reason, and you can show that you have collectively done that because you were all convinced that this person was ready for unsupervised practice, you have a much stronger case than even if you have used a form that suggests that something is objective, but it's actually pretty reductionist approach to assessment.
Yeah. Yes. Yeah, I cannot agree less with you, but you're the expert on this, so you had the last word. But this was the last question. We could talk about this 2 hours more. We're not going to do that now, but I want to try to, maybe if we had a lot of questions, we can later have a Q&A session again. We'll let's see how that works out. For now, I only can thank you very much for your contribution to this session, to this webinar. Professor Olle and Cate, thank you very much. Professor Creugers, very much. Robert Smeenk, very much. Thank you. I see in the timeline on the side that a lot of people tell us how interesting it is. So that's also nice to see. And the last remark, I go to my presentation again. Let me see. I think I have one more slide. That's this one. Yeah. Please give a warm applause for our speakers. I will do it. I don't know anyone can hear it, but maybe only mine you can hear. And for now, thank you very much. You can use this a QR code for an evaluation. I would like to hear from you feedback, of course, about the seminar today. You can also have some extra questions in there, and we hope to see you in the next upcoming events. And if you leave your mail address, we inform you about that. So I think this is it for now. Thank you very much again, and we hope to see you again, and we enjoyed it very much. Bye bye all.